I'd like to welcome you to this webinar sponsored by CHEST and in collaboration with AstraZeneca, where today we're going to talk about the role of the pulmonologist in the multidisciplinary approach to the patient with newly diagnosed lung cancer. What I'd like to do is just go over a few ground rules. What we're going to do is have a really great sort of fireside chat after a presentation by one of our panelists about what is a multidisciplinary tumor board. And then we'll review some questions that I think are germane to anyone caring for patients with lung cancer and how those tumor boards interact, what they do, what value they bring to their community and their patients. And then we are absolutely going to open it up to our viewers and ask you to use the Q&A button to ask questions that you might have. And so if we can just go to the next slide, please. Just again, like to welcome everyone. I'm your moderator. I'd like to introduce our lead facilitator. Katie Sears is an assistant professor of medicine in the Division of Pulmonary Critical Care Medicine at Indiana University School of Medicine. She's put together a wonderful talk to help us review what is a tumor board. Next slide, please. Kristin Higgins is at the Winship Cancer Institute at Emory University. She's an associate professor of radiation oncology and the medical director of the Emory Clinic Department of Radiation Oncology. An absolutely wonderful radiation oncologist who spends really most of her time caring for patients with lung cancer and working in the research arm of her institution. Osarogiagbon is the leader of the Multidisciplinary Thoracic Oncology Program at the Baptist Cancer Center in Memphis. He's an oncologist, and Ray is particularly interested in disparities in looking at health systems and how can we take the quality of care we view at some of our academic flagships and move it out into the community to provide care in rural and underserved areas. And he's absolutely wonderful at this. Also an expert in biomarker, use of biomarkers in the treatment of and treatment selection for patients with newly diagnosed cancer. Next, please. Frank Detterbeck is the foremost thoracic surgeon in academia in the United States. He's the writer of the practice guidelines on lung cancer. He is at the Yale University. He's the chief of thoracic surgery at the Yale School of Medicine, has led tumor boards both at Yale and at the University of North Carolina, Chapel Hill for years, and probably really has so much experience with working in that realm. And lastly, John Longshore is PhD. He's director of molecular pathology at the Carolinas Pathology Group of Atrium Healthcare, a very large healthcare consortium in Charlotte, North Carolina. And John is an absolute amazing resource in how to work with thoracic pathology and also how to do molecular testing in a streamlined fashion. So we have a great panel today of experts from all across the United States, and I'm just so pleased to be a part of this. I'd like to turn it over now to Katie Sears, our young burgeoning superstar in lung cancer, who's going to talk to us about the critical components of multidisciplinary lung cancer programs. Katie?
Thank you for that introduction. This is my disclosure slide, and I'd also like to disclose that I made this talk for pulmonologists primarily, but hopefully you'll be able to see that this is truly a multidisciplinary effort. But I always like to start with the problem, right? And so I live in Indianapolis, and this is our NFL stadium where the Colts play, Lucas Oil Stadium, and it seats 68,000 people. Now, if you look at lung cancer, this just gives us a perspective of how big the problem is and how much we really need this multidisciplinary best care with more than 3 times the number of patients in the stadium being diagnosed with lung cancer every year and more than twice this number dying from lung cancer. Now, I think we'll touch on this later, but one of the reasons for a multidisciplinary lung cancer management program is all of the advances in lung cancer. So if you go to the next slide, I'll just kind of talk about a few of these. All right, so obviously, press, please. Obviously, this is the way that we've always kind of thought about lung cancer on the 10,000 point view, but of course we all know with over the last several years that lung cancer has become increasingly complex. And this also pertains not just to treatment, but we have to think about this when we're diagnosing lung cancer as well. Go ahead, next, please. Again, increasingly complex is how we stage lung cancer. And thinking about even the mediastinal staging, we already have 3 procedures or more we have to think about, and that involves multiple disciplines, multiple thoughts, radiologists to understand what might be involved. And so even staging lung cancer is increasingly more complex. Next, please. And then, of course, diagnosing lung cancer is becoming increasingly complex. And as pulmonologists, we know this. Interventional pulmonology having an even greater role in diagnosis, not just of central lesions, but of these peripheral lesions through guided and more advanced interventional procedures. But of course, we have to look to our radiologists for percutaneous biopsies, surgical biopsies, and when that would be appropriate. And all of these different factors need to be included, including now things like liquid biopsy, which may be appropriate in some patients. So obviously knowing what's out there, knowing what's available, and of course what's available at your institution, which may be different than another institution, is really quite important. And as I discussed earlier, these diagnostic techniques are constantly and rapidly changing. So that definitely benefits from multidisciplinary involvement. Next, please. So again, all of these advances in care and things I haven't touched upon yet really highlight the increasing complexity across multiple medical specialties and underscores the importance of having a multidisciplinary group in your care and management decisions for lung cancer. Next, please. So I think most of us are familiar with the team on the left, and this is what we typically think of when we think of a multidisciplinary lung cancer team. We have everything from medical oncologists to pulmonologists, thoracic surgeons, and radiation oncologists, pathologists, and radiologists and nuclear medicine radiologists and palliative care. But things that we may not think about as much may have a very important role in the multidisciplinary management of lung cancer. Things like our cancer care coordinators, case managers, and social workers, who are very important, particularly later in treatment, but even early on. Pharmacists and maybe even research pharmacists that are involved with patient care, interventional pulmonologists, who often are not the same pulmonologist seeing that patient initially at some places. And then, of course, nutritionists, smoking cessation teams, and then I'll touch upon lung cancer screening programs and how they may be a good part of the multidisciplinary lung cancer team as well. Go ahead. So this is traditionally how we think about diagnosing and treating lung cancer in a very linear way, where we get referred the patient, we do an assessment, we get the initial imaging, leading to all of these different diagnostic techniques based off of presumptive histology, getting the final diagnosis and stage, and then going on to the treatment plan. But I think those of us who are involved in lung cancer care often know that this doesn't always work, that sometimes we get all the way to the treatment plan and realize that additional molecular testing or additional biopsies are needed. And we have to go back either to another evaluation by a different specialist or to another diagnostic technique, really multiplying different things and taking more time. So if you'll go to the next. So really what a multidisciplinary lung cancer management program does is it combines a lot of these steps and really streamlines the process. And some of the things this can do includes improving the staging and diagnostic accuracy, increasing the evidence-based treatment, reducing the time from diagnosis to treatment, minimizing unnecessary procedures and delays, ensuring that the necessary procedures, molecular markers, and other studies are actually done, decreasing patient anxiety, patient visits, and time burden, improving patient satisfaction, and potentially improving provider satisfaction and streamlining our workload. Go ahead. So just a little bit further to look at what the problem is. This is a collection of studies looking at time from either diagnosis to treatment or time from suspicion to treatment in lung cancer. And as you can see with some of these studies, it's quite a long time that these patients are waiting from either diagnosis to treatment, or from suspicion, finding a nodule or finding some lymph nodes that are enlarged, to actual diagnosis and treatment. And so you can see there's a real need to speed this up. Go ahead. And really, when you look at that timeline, any one of these things can be, can increase in time. And so, decreasing any one of these steps really decreases the entire thing. And if you can get multiple steps done at the same time, you can see how the time from diagnosis to treatment can really be decreased. Go ahead. So what's actually out there about multidisciplinary care in lung cancer? As you can imagine, it's very difficult to do these studies looking at, the impact of a multidisciplinary care on lung cancer outcomes. There has been one randomized controlled trial which looked at multidisciplinary care versus standard of care. They used a two-stop approach, basically where the initial evaluation, imaging, and biopsy would be done at one visit, and then a multidisciplinary discussion would be done at another visit. And what they found was that this did reduce the time to treatment about in half, that patients were more likely to receive chemotherapy. They did not find a difference in survival in this, but we'll talk about that a little bit later. Now, there's available data from single center pre and post studies, multidisciplinary compared to non-multidisciplinary retrospective studies, and then multiple systematic reviews. But realize as we discuss these that there are lots of variability in programmatic approaches to multidisciplinary care, and that differences in the patient populations. So what I tried to do, if you go to the next slide, is I tried to kind of give you an overview of what these studies have shown in general. So overall, these studies largely showed that, or most of them showed that there was a reduced time from diagnosis to treatment when you used a multidisciplinary approach, that there was decreased patient anxiety, increased patient satisfaction and quality of life measurements, more complete staging, so more patients were actually had the staging completed, and an improvement in guideline-specific treatments. In addition, there was variability in measurements of survival, but the outcomes were particularly good in those patients who had late-stage non-small cell lung cancer. That included improvement in guideline-specific treatment, and for the most part, that those studies looked at chemotherapy in these patients. That these patients had the highest improvements in quality of life measurements, and that many showed improvements in progression-free survival and overall survival. And in particular, there was a study in the UK and in medically inoperable non-small cell lung cancer patients who had almost a double median survival. Another cohort in Texas had improvements in overall and progression-free survival, which may not look like much until you realize that these were advanced stage non-small cell lung cancer patients only. This was also replicated in a Taiwanese cohort in which there was an improved 3-year survival in stage 3 and 4 patients, and also in an Australian cohort which showed overall survival in 1, 2, and 5 years with the use of a multidisciplinary diagnostic care clinic. Next, please. So what about the cost? I think a lot of institutions in particular, maybe not us, but a lot of institutions worry about cost, and will this increase the cost to them or to patients? And there was actually an abstract presented at CHEST this year, which looked at one center. You can see the number of patients, and it was about 1.5 to 2 years time. And they looked at basically cost to the patient and cost to the institution. Now, there was about 1 fewer visit from diagnosis to treatment, which doesn't sound like a lot, but of course, 1 fewer treatment for all patients is not insignificant. And if you look at the total cost reduction, which included the cost to the clinic as well as the cost of the patient, it's quite large. But the main benefit was to the patient. So there was a significant cost estimation to be saved to the patient on lost productivity and time. And there was a modest decrease in cost to the clinic. But I think taken from this, you can at least go back to your institution and say, well, from what I found, obviously an abstract, but there doesn't seem to be an increase in cost to the institution. And so if it improves outcomes and doesn't increase cost, it's likely to be good. Next slide, please. So what about a multidisciplinary tumor board specifically? Well, what can it do? It can facilitate diagnostic evaluation as well as treatment decisions, and then provide guidance on tissue needs and desired molecular testing even before the diagnostic tests are done. Provides consensus on staging, varying opinions on treatments, enhances communication between your colleagues and collegiality between specialties, improves interdisciplinary exchange for new and varying opinions, and provides evidence-based education on new and emerging therapies. In particular, I'd like to point out that a lot of virtual platforms that have been really improved upon over the past year can provide assistance to rural and less specialized centers and maybe areas that don't have certain diagnostic or therapeutic techniques to improve their ability to provide that to their patients. Next, please. So looking at tumor board specifically, there have been some studies looking at that, and they show largely the same outcomes, particularly improved survival and improved outcomes in late stage non-small cell lung cancers, and improved timeliness in diagnosis and treatment. And one in particular looked at a place that had a multidisciplinary clinic. The multidisciplinary clinic had to close, but they continued with their tumor board. And they found that even with the tumor board, they had improvements in diagnosis to treatment time. Additionally, tumor boards often lead to changes in treatment decisions. And so, obviously having multiple people involved may lead to improvements in that as well. Go ahead. So what about lung cancer screening? Obviously, lung cancer screening affects a multidisciplinary lung cancer tumor board or clinic in multiple ways, not least of which is the fact that it increases the overall number of cancers diagnosed. But it is kind of special in that it increases the proportion of stage 1 cancers. And multidisciplinary involvement with the lung cancer screening program can help with streamlined diagnostic and therapeutic evaluations, help with patients that are presenting with symptoms at the time, so they may not be good for screening, but you may be able to just go ahead and immediately get them into the person that needs to see them. And they can be helpful in reviewing atypical and incidental findings that radiologists or others within that group might be able to help with. Next, please. Other potential benefits that we may touch upon in our panel include helping with the diagnosis and management of treatment-related side effects, things like pneumonitis from immune checkpoint inhibitors and radiation, scarring from radiation, including SBRT, and sarcoid-like diseases that pulmonologists may be able to help with, as well as in the clinic, more rapid management of common comorbidities we see with lung cancer, rapid evaluations of symptoms and referral to palliative care, including discussions with interventional radiology for things like tumor debulking or management of metastatic disease that we may not do. Expediting evaluation of possible recurrence and case management for financial and non-medical stressors. And then I don't think it can be stressed enough that caregiver assistance and inclusion in care plans is really important. And having multidisciplinary groups, particularly with nurses and care managers, can help with this as well. Go ahead. So in conclusion, I think I've shown that multidisciplinary care for lung cancer can improve time to diagnosis and treatment, improves patient quality of life and decreases anxiety, increases patient satisfaction and improves evidence-based treatments. It can change lung cancer management and often does. It may improve survival, particularly in those with advanced non-small cell lung cancer, and may streamline things like tissue acquisition, diagnostic processes, and evaluation for critical molecular markers that might be necessary to establish a treatment plan. It may provide a pipeline for those who are screened for lung cancer that might benefit them. And then it may aid in the management of other non-cancer issues surrounding our patients with lung cancer without adding burdens or referral to another clinic. And I think that's it. So thank you very much.
Thank you so much, Katie. I don't know if you can see me, but I'm beaming with pride to see our young next generation of superstars grab the helm of lung cancer in the pulmonary community, and you're certainly one of those. We would like to ask people if they have questions to put them in the Q&A part of the box. I did see in the chat part of the box Arnie Schwartz, who's a pathologist and great friend of Chest, say that not only does Tumor Board help with everything that Katie mentioned, but it is a way to introduce clinical research, and we're going to get to that and work on things like basic and clinical research where patients can get put into clinical trials. Less than 5% of lung cancer patients ever make it into a clinical trial, which is sort of a shame. What I'd like to do now, as we get to the questions popping in, is I'm gonna really challenge and have everyone on the panel unmute, and I'm gonna challenge our panelists to talk to each other and talk to me about different aspects of a tumor board. And so the first question I'd like to pose to Kristin, our resident radiation oncologist. Kristin, what aspects of tumor board bring you the most value, you as a clinician? Which part of that brings you the most value?
So that's a great question. I think one of the unique things about lung cancer over the last several years is that things are changing very rapidly. We're seeing changes in adjuvant therapy after surgical resection. We're seeing dramatic changes in the systemic frontline therapy for advanced lung cancer. We're seeing changes in the types of radiation that we're recommending to patients. And it's hard to keep up with all of this information, especially that information that's outside of your specialty. So bringing everybody together in one room, we learn about the latest advances in interventional pulmonology, for example, and what sort of new techniques you may have. And that dialogue amongst the different specialists is really valuable. I learn so much from my colleagues every tumor board that I come out of. And I think that learning that we go through then translates to better outcomes to our patients. And it's really, I think, one of the number one things that I do every week that keeps me abreast of everything that is changing so rapidly in our field.
That's awesome. Ray, I want to jump over to you. I've seen a slide that you've made in the past, and could you just tell the group just how many new drugs that require molecular analysis during the diagnostic procedure have come through the FDA approval process and have shown great benefit in the past few years in lung cancer? I wonder if you could just comment on that, please.
Yeah, Gerard, interesting. As recently as December 2020, with the breakthrough designation for Amgen's 510 that targets KRAS G12C, we now have 10 different specific subsets of non-small cell lung cancer for which there's FDA-approved specific targeted therapy. 9 of them are oral targeted therapies. 1 is for checkpoint inhibitor therapies, so people who have a PD-L1 greater than 50%, we must not forget that. Those people do much better with immunotherapy than given what I now call dumb conventional chemotherapy. So 10 different subsets and rapidly changing.
And Frank, I wonder if I could, ask you to comment on the fact that it used to be that surgeons could sit at the tumor board and not get involved in the biomarker discussion, but that's recently changed. Do you want to comment on how much this is starting to invade the surgical realm in adjuvant therapy?
Well,
go ahead.
Yeah, there was a recent study that really suggested showed, I should say, remarkable, benefit to adding targeted therapy, Dura trial. So, you're certainly right that, the field is constantly changing, constantly advancing, and it's hard to stay abreast. As far as the thing that gives you the most satisfaction, if you were to ask me, I would say that, if there's one thing I've learned, it's that surrounding myself with smarter people is a huge benefit. And I think the biggest is that I feel that I'm making much better decisions because I've got the expertise of a bunch of people weighing in on, how best to proceed.
Awesome. Katie, I'd like to run back to you with this question of tumor board decreasing time. I've had both patients and some physicians say, tumor board's not till Thursday, it's Monday, patients getting anxious. What do you mean it decreases their time to treatment? How should I respond to those folks?
Well, I think the reality is the bulk of literature out there shows that it does. So I do think looking at, different institutions, they do things differently. So many institutions have tumor boards more than once a week. Some institutions don't have the bandwidth to do that, but I think it depends on your patient volume. And so, I would argue that tumor boards are the most effective when you use them early, right? And I think that some of the benefits of tumor boards really extend beyond the tumor board itself. So if you are, meeting at least weekly with your colleagues in a multidisciplinary group, and something needs to be done for a patient, they need to be evaluated, or they need some sort of a diagnostic before their treatment, it's a lot easier to call someone up who and you've been meeting with every week than somebody that you honestly don't know very well and say, listen, can you get them in this week? Can you get them in next week? We need this done. So I honestly think that some of this benefit may be those types of, difficult to measure, unmeasurable things that go along with a multidisciplinary care group that includes tumor boards or multidisciplinary care clinics.
Great.
Katie, can I jump in here for a second?
Sure.
One of the questions that was asked in the Q&A is, what should be the standard time frame for making a diagnosis and starting treatment? Is there a standard? What sort of benchmark would you throw out there?
You want me to take that, or
Katie? Yes. What do you think?
So, there are different societies that have put out recommendations. And so, we could go through that. I think the reality is, and I believe we don't have one as a standard here, but I believe in the UK, they said, time from diagnosis to treatment, it had to be 30 days is what I believe that number was. We don't have one here, but most people would argue that 30 days is probably what you're aiming for. But I think that also depends on the stage of lung cancer, right? Because we know that, for instance, with the stage 1 lung cancer, your treatment, there's been studies looking at surgery, right? That maybe surgery can go as far out as 3 months. But we all know that time, is of the essence, and that some of these studies don't capture an individual patient's experience. So, I would say that most of what, kind of larger government healthcare systems, things like that, have recommended is somewhere in the 30-day mark, 30 days to diagnosis, and then 30 days from diagnosis to treatment. But, I think we all know that may change based off of the characteristics of the patient and the need to really speed that up. And I think that's why a lot of the studies show it's a lot easier to show a survival benefit in later stage non-small cell lung cancer, right? Because you do have a little bit more time in smaller ones. I don't want to say just to take as long as you want, but the reality is we know patients with advanced stage lung cancer die more quickly. So getting them in may make a bigger difference.
I want to throw that question to John Longshore, pathologist, because we had a really strict, we keep our data in my multidisciplinary clinic, and I wanted to make a diagnosis and have them presented a tumor board within 2 weeks of their first presentation, so then we could talk about treatment options, and absolutely in the next 2 working weeks, get them started on treatment. I think the one thing that has occurred, John, is that oncologists, pulmonologists, people who really believe in the need for biomarker testing have seen some barriers, not necessarily barriers, but some delays in starting treatment. And I tell you that at our place, we really push back and say unless it's a grave situation, we're really not going to start treatment until we have our molecular markers back, because if you give the wrong treatment for the wrong disease, you're probably not going to benefit your patient. John, do you want to comment on whether you've seen that push-pull from pathology to the tumor board and how you've addressed that as an institution?
Yeah, I mean, certainly you do see that. And one thing you want to make sure you have in a multidisciplinary tumor board is that it is multidisciplinary. It is not there for one specialty to dominate discussion, but it's a collegial discussion among all the specialties. And really the role of pathology in multidisciplinary tumor boards is really fourfold, I think. First and foremost, we're often associated with making a histological diagnosis. We play an ever increasing role now in biomarker profiling and promoting comprehensive biomarker profiling, making sure that we work with our colleagues based upon the amount of tissue that's available to select appropriate methods for comprehensive genomic profiling or single gene assays in some cases where there are insufficient tissue, how to integrate the liquid biopsy. We're also involved in clinical trial decisions. We may be sending unstained slides or blocks out to a central pathology operation to accrue patients to clinical trial, and also making sure that there's sufficient material left at the end to send to the biobank for future use and future biomarker profiling. And I think really the way that we accomplish a lot of these tasks best is what we call reflex testing or universal testing. We've had in my institution for many years, and it really is the gold standard around the world to have pulmonology or pathology-based biomarker testing. So as soon as a histological diagnosis is made, we are able to order the appropriate biomarker testing instead of waiting for another provider to do that. So that's a really big impact on patient care, and it does two things. It not only increases our testing rate, but it also increases our effective testing rate. So the effective testing rate is really the goal that we are shooting for, to improve that. And that would be, at the time that an oncologist has to make a therapeutic decision, we want to have all the biomarker test results available to them and in their hands so they can make an informed treatment decision.
Hey, John, can you, to follow up on that, can you tell me how often you revisit your panel? So if you're, Ray was telling us that, hey man, like we just got another FDA approved drug, we're up to 10 or 11. Do you get together with your group, your pulmonologist, your oncologists? Do you stay abreast of the literature? And I've heard that, pathologists are basically like you guys are a scarce commodity these days. And so how does a pathologist, particularly in a community setting, keep up with all this? Do you regularly say, hey man, I got to look at my panel or what I send out and what I reflex?
Yeah, that's a great question. And we certainly have that challenge in my system. We have over 50 hospitals and facilities in the system, and some of them are large academic type settings, but the vast majority of them are community-based settings. And we have the goal that, the quality of oncology care a patient receives should not depend upon where they present for their oncology care. So we have pathways for diagnosis, for biomarker testing, and for therapeutic selection that we use across the system to really help standardize cancer care. As far as revisiting the panel content, for many years, both the NCCN and the CAP, ISLC, AMP guidelines have called for comprehensive genomic profiling for lung cancer patients. Comprehensive genomic profiling is a very inclusive term and is not very well defined in some operations. But generally speaking, most comprehensive genomic profiles that are used across the U.S. for oncology care in the lung cancer space include not only approved biomarkers, but also emerging biomarkers. So it helps us stay ahead of the curve and not necessarily have to change the panel when an emerging biomarker that's been in clinical trials for some time becomes approved by the FDA or included in the NCCN treatment guidelines.
That's great. And you mentioned, I'm going to switch gears and ask Ray to answer this, but you mentioned, John, about the collegiality and making sure someone doesn't dominate the discussions. Ray, how do you adjudicate disagreements and build consensus at your tumor board? And then also, how do you report back to your patients after that consensus is built?
Thanks, Gerard. Yeah, that's a little bit of a touchy challenge, especially when you first start a program in an environment in which it is alien. Especially in the community, so-called private practice world, people are used to coming and going as they will, as they please. People are somewhat entrepreneurial. They tend to be much more autonomous in their behaviors and their expectations. So this idea that suddenly you come to a forum where you check your ego at the door and let the evidence be what drives decision-making can be challenging. And one does need to be very sensitive to that fact. The ways we have approached it, we have agreed that as much as possible, we will use the evidence. We don't want it to be who has the loudest shoe thumping on the table to be the thing that drives what gets decided. So we use the NCCN guidelines as one set of guidelines. We use the ACCP guidelines as well. We actually have that available, in real time, where you click it and, you have the big screen that shows what the guidelines are. We just sort of walk through them. The other is we agree that we will come to consensus around each case discussed. So at the end of time, everybody understands that wherever you start from, at the end of that discussion, we have to come together. It's not like an NIH study section where you can, spend all that time. At the end of the day, everybody walks away with a different vote. Here, we have to agree. And the third thing we do is we're very compulsive about measuring what we call our concordance rates. So the idea is, because of prior work we've done, we have demonstrated that if you're not careful, these multidisciplinary forums, you have your wonderful debate and come to agreement. And then when you come back a year later to find out what actually was done, we found in my institution, 40% of the time, something different was done. And the patients who got that discordant care, the outcomes were worse. So we got into this idea of benchmarking our concordance rate, asking for it to be north of 85%. And then the other thing we do is we give everybody skin in the game. So we share the responsibility for moderating each conference. We actually have a rotation of pulmonologists, medical oncologists, surgeons who are willing to make the commitment. So these are some of the things that we've used.
That's so great. I'm going to add two other things to that. Sometimes, Ray, based on patient preferences, there is no right answer, right? So it could be, for example, a decision to do a limited surgery in a patient who's elderly with poor pulmonary function versus SBRT. And we might get the opinions of the group. And I will tell you, the one thing we actually do in our group sometimes is vote. And I actually tell my patients before tumor board, I'm going to get a consensus. And if it's 18-1, I'm going to tell you 18 of us felt like, surgery was the right choice. And one person, voted for radiotherapy. And if it's 10-10, I'm going to also say, hey, this is one of those decisions that there's no right or wrong. Let you meet with both of those doctors and make a decision that fits your internal preferences. And I think sometimes we don't do that enough in these tumor board discussions. As far as reporting back, we tell them, our tumor board's Wednesday, 12 to 1:30, and you should expect to receive a call after 1:30, but on the same day before we leave work that day. And patients are anxious for that call. And so for the people listening on the line, I would urge you to understand how stressful it is. And in psychologic studies in the past, they've shown, you would think that the most stressful time for a patient with cancer, particularly lung cancer, is right before they might pass away, but it's actually not. It's between the time that they've been told they may have cancer and they receive their first treatment. That is the most stressful time, the uncertainty, the unknown. And so if we can make sure that we're reporting back to them. Finally, we record in the medical record, in our EPIC medical record, our cancer clinic coordinator records the discussion. So it's there for everybody to see, right? We have it recorded. So, a week or two later, we can say, hey man, we said we were going to do this. What, did we make sure it happened? So I'm going to go to the next question, which I'd like, well, you know what, I'm going to skip it so I can come back to Ray. Ray needs a little time off. I'm going to ask Kristin this question. Do you think sometimes that patients, I've been asked this by clinicians when I'm out lecturing, is they say, hey, don't patients lose confidence in you if you say, hey, before I give you my final opinion, I'd like to present you your case at our tumor board. Doesn't that make it seem like you just don't know what you're doing? And do you think it either builds confidence with them, or do you think they have less confidence in you by saying, I'd like the collective group to to weigh in on this before we give you our final recommendation?
In my practice, I found it's just the opposite. I think that it helps to build trust with the patient when you say, there are multiple ways of doing things, and this is a shade of gray. This isn't black or white. So I really want to see what the collective group thinks on this topic. And, I say, look, 10 heads are better than one. This is your life. You want a lot of different opinions. And almost unanimously, my patients agree, and they love the fact that they are getting all of these experts to look at their exact situation, and they don't mind waiting. If anything, I think they have a sense, they feel reassured at the decision that's being made. They feel like they had a chance for a second opinion, yet they didn't go anywhere because their case was presented at that tumor board. So I really have not found that to be a barrier to tumor board presentation in any way, shape, or form.
I totally agree. And I honestly think it's a huge patient satisfaction piece. And I think it's something that you can honestly advertise if you're a community in the community setting and you want to provide this high quality care. Advertise that you have this multidisciplinary group that's going to look after you and treat you like their family member. I think it does nothing but, add to our, stature among our patients. And particularly when we go back to them, down the road a year later, say, hey, look, I want to bring this back to the tumor board. I'm at a stalemate here and I need a little bit of help from my friends. I don't think, and I tell them, look, I'm pretty confident in my abilities, and I think this is what they're going to say. But you know what? Like, I'm not, as Ray said, I'm going to leave my ego at the door and work with it that way. So I couldn't agree with you more. And that's the answer I give both my patients and providers who sometimes see it as superfluous to what they do.
Gerard?
Yes.
I see a question that, I find is often asked, if you're recording the tumor board discussions in the medical record, does that open everybody up to liability? You're obviously doing that. What are your thoughts about that?
Yeah, I don't know how to answer this other than to say two things. One, I work for a state institution, so I can't be sued individually. My university can be sued, but I'm okay. And I know that sounds like a trite answer, but I think actually, if you follow up with what you said you were going to do at the tumor board, not only are you helping yourself, I think for any of us who've been asked to defend a physician in a lung cancer case, that type of documentation absolutely helps the provider. You've had the discussion, you're thoughtful, you bring to the table everything, you document that you said, hey, the tumor board collectively, there's more than just me. So, right, if they're going to go after us, they're going to come after all of us, and we're a team, right? And so we decided collectively this was the best course of action, even if things don't work out. So I actually see it as a protective mechanism and not one that you can that you could have liability with. Now, Ray may disagree with that and say, look, well, we found that 40% of the time they don't follow those recommendations. But, maybe that's why we should make sure that we're following what we said we'd do in the tumor board.
Yeah, Gerard, I'll jump in and actually completely agree with you. That 40% discordance was work that we did when I was at the University of Tennessee. And then we got PCORI funding to actually implement multi-D care so we could do a comparative effectiveness trial of multi-D versus serial care. And in the process of trying to implement it, my healthcare system is 120 years old, extremely conservative, very, very financially successful, even though a not-for-profit organization. And their legal team is like a fortress. So when you brought this idea of multidisciplinary decision-making, and then, wanting to put records, a paper trail down and all kinds of things in Epic, we really, I had to sit with our legal team. And ultimately, we actually put together a paper that, looking at legal perspectives of interdisciplinary care delivery. And one of the things that came out is actually the legal obstacles are superficial. People talk about Stark laws, anti-kickback laws, you may be vulnerable to this and that. But in practical reality, as we dug into it, the medical legal perspective is actually very strongly in favor. It is very, just as you said, Gerard, it is very protective to be able to say, this was a consensus recommendation from our group of experts. I'm sorry things didn't quite go the way we would have loved, but what are you going to do? So absolutely, it's the exact opposite of the superficial response that people might want to have.
Thank you so much for that.
I think what you should probably include, though, is that it has to be well documented, right? So just having the discussion and saying, well, we had a tumor board, probably doesn't help you legally. But having it on paper and that this was discussed with the patient afterwards, et cetera, I agree, probably helps you medico-legally.
Yeah, I would say that we have a template and we make sure that we state whether it follows NCCN or CHEST guidelines. We put down the appropriate stage. We put down the question needing to be answered. We put down the answer to that question. We put down the follow-up, referral or what have you. So it's a template and it comes every day. And guess who has to sign it? If it's my patient that I'm presenting, I'm signing that. So I'm looking at it and making sure I follow up. And that's just good medicine. Katie, while I have you on, can you tell us, other than case presentations, what other activities does your tumor board engage in? So is the whole hour and a half about cases, or do you engage in some other activities?
Well, I think yes, we do other things. So first we have our cases and we make sure we get through those. As we've gotten busier, it becomes difficult, but we do set aside time for presentations on new areas within lung cancer. So we typically have the different disciplines discuss any new, for instance, medications, so personalized therapies within their area. We talk about diagnostic techniques and kind of go through some of the risks, benefits, and what's available. We go through we went through liquid biopsies not that long ago and what we use and why. So, and when to implement it. So you get some educational component, some of it more practical and some of it more kind of evidence-based and newer therapies. In addition, we discuss our research. And in particular, we often will bring up if patients are candidates for research studies. So any new research study that's ongoing gets presented at our tumor board so that there's, basically everybody knows about it and can either refer through the tumor board or refer outside if they see somebody that would meet that. And then in addition, we have added our nodule evaluation multidisciplinary discussion to the end of our tumor board. So this is mostly used for our lung cancer screening program. And we use it also, though, to discuss any really difficult diagnostic cases. So patients where there's a lot of questions on, hey, we don't have a diagnosis, we think it's cancer, what should be the next step? And then we also use it for, potential treatment-related lung diseases that have come up. So we can discuss that in a multidisciplinary group. So I think those are some of the other things that get discussed at our tumor board.
Yeah, so those are all things I think we would all agree with. I'm going to add one or two other things. Sometimes we celebrate a birthday. So there's honestly a social aspect. It's been much harder in COVID because we're all doing Zoom tumor boards, most of us, I suppose. But these are our friends. I think I can't underestimate the fact that when you start doing one of these multidisciplinary clinics where for us we have 8 doctors in 16 rooms around a huge pod, surgeons, radiotherapists, pulmonologists, oncologists, these are your friends, right? You're right next to them and you know about their families and so we actually try to acknowledge people's accomplishments at our tumor board. We acknowledge birthdays, we acknowledge births and retirements, and not just for the core team, but for everybody else who supports us. And Kristin, I'm going to ask you a question I didn't review beforehand, but it's come up in my mind, which is, if you were starting a new tumor board today, and you could have any one thing, it could be technology, personnel, it could be anything, space, what what one thing do you think is most important for the running of a successful tumor board?
I think it's important to have a tumor board coordinator who can take care of all of the logistics, getting the cases on for the week, scheduling, getting the room reserved, or working the online platform that you're using, so that when the doctors join at the end of the day, or then the rest of the team, everything is seamless. So I think that that's a really important part of the behind the scenes of the tumor board. And another really useful thing for these tumor boards is that you just have to jump through a couple of hoops and you can get your tumor board to meet CME, such that you achieve your CME requirements for your medical license just through that weekly meeting, and you don't have to worry about holding on to other CME conference certificates and things like that. And then that's another, I think, big benefit to this.
Yeah, we are certainly CME certified, and I'm so glad you said that, because if it's me, and I'm pretty sure every other person who works in a multidisciplinary setting, the coordinator, I can't emphasize enough how critical the coordinator is. Everything from working with patients to scheduling multiple visits with different providers at the same time, back to back to back. For scheduling testing, for tracking down things that might not be going right, and I think, and I want to put this out there, I think we're talking as physicians now, but this is a system issue. And if you're thinking about the participants on this webinar about starting or improving your multi-D tumor board, that is an institutional requirement, and we have to hold our cancer centers or our hospitals accountable to making sure they provide that resource. Of any resource, I can do without space. I think I can do without some things. I don't need the newest, fanciest PET scanner, but I need a coordinator, and it is so vital to patients. Our patients come in and they can't wait to meet Claudia, that's my coordinator, and hug her and tell her how much she made them feel better about everything going on. They ask by name to meet with her. So I think a coordinator is absolutely critical, and I think getting support for that is important. The same way you would get support for a piece of equipment, the same way you would get support for recruiting another physician. That is a vital piece of the program. So I'm going to go back to Ray for a moment and ask him, what is his feeling about not virtual tumor boards in his institution, which I think we're all working through right now, but how about virtual tumor boards with outlying community hospitals? What's the view from from them in terms of the value they get, and does it work, and what are the barriers to getting that going?
Yeah, there are barriers, that's for sure. But where there's a will, there's a way. My healthcare system is far-flung. We cover 107 counties through 6 major hospitals that provide the full complement of thoracic oncology care, including surgery. In 3 states, catchment area spills into 6 states. So right at the heart of the U.S. cancer incidence and mortality zone. We got a few counties in southwest Kentucky, but the heart of our catchment areas is Mississippi, all of the state of Mississippi, West Tennessee, Eastern Arkansas, spilling into parts of Missouri, Boot Hill, and parts of West Alabama. So you can imagine these are some of the poorest states of the union, and they're predominantly rural. They are far-flung. So connecting is actually one of my big ongoing challenges. We actually have a 10-year plan. We call it the Mid-South Miracle, that is designed to actually change population-level lung cancer mortality, because we want to building these programs out. One of the 7 major programs is multidisciplinary treatment planning. And the barriers to multi-D implementation are really lots of barriers, but the 2 key ones are barriers of time and space, if you want to think conceptually. Mm-hmm. So the barrier of space is, okay, where do we meet? Where's the environment? Where's the forum? Well, technology can help you overcome that. You know, we're doing virtual tumor boards now, and by force because of COVID, and I think a lot of that is probably going to stick at the end of the pandemic. But the barriers of time, that's the really tight one. You know, time is money, right? Time is the most precious resource we have. And we have so many different people in so many different places with different, schedules. How do you yoke them together in the same time to interact? There is some opportunity for technology to come into play here. You can begin to sort of have cases that, can be put out there and people weigh in. And then after a short period of time, you develop the consensus and then roll that forward. But there is a huge opportunity because we have shown, at least in my healthcare system, that the quality of care is incredibly heterogeneous. It is not nearly the same. And one of our goals in the Mid-South Miracle is actually to eliminate that. So it shouldn't really matter at what point you get into the healthcare system. We want to make sure the care is uniformly high level, and it's this interdisciplinary interaction that's going to get us there, we think. So yes, big deal.
I'm going to give you the last word on that, Ray. That was incredible. And now I'm going to go through and ask each of our participants for one final thought. Frank, first I'd ask, are there any more questions from the audience?
No.
Okay. So Frank, can you give us one final thought quickly so I can get around the room?
Well, I think that it takes time to really do this. At the same time, I think that you save time and you feel that you are able to deliver care more efficiently by doing this. When I say it takes time, I think it takes time to get together as a tumor board. But one of the things that we do is we have a monthly evening session where we say, hey, there's some new papers that have come out. This probably requires us to modify our care plans, or we have a bottleneck that we don't deliver care as quickly as we'd like to. How do we solve this? But those investments of time, I think, are crucial. I think you have to get the buy-in to get the benefit from it, to realize that this is, in fact, it's a worthwhile investment. But I would encourage people to do this because investing that time pays for itself multiple times.
Kristin.
Yeah, I would say it's the best hour of your week. You're coming together as a team. It helps you do the best thing for the patient, and you continue your education and you learn. And you're killing a lot of birds with one stone, and it will improve your efficiency and your work quality of life, I think, overall.
John.
Yeah, I think one thing that my system has done very well is we invested heavily in technology for tumor boards about a decade ago. And we have our tumor boards at 7 in the morning, at noon, or 5 p.m. in the afternoon. We have, at least prior to COVID, options to attend in person as well as virtual or simply phone-in options. And when you invest in technology for multidisciplinary tumor boards, you really eliminate the excuses that people have not to participate, because there's always a way they are able to participate. So I would encourage you to think beyond just simply having an in-person tumor board.
Katie.
Well, I would just say don't be intimidated to get involved, particularly as a pulmonologist. I think we often feel that we kind of diagnose lung cancer and hand it off. But hopefully through our discussion, we've kind of talked about some ways in which I think pulmonologists actually can play a really critical role, not, obviously in the diagnostic portion of a multidisciplinary care team, but also in the therapeutic portion and having that input from a multidisciplinary group makes you a better pulmonologist. It makes you a better physician to treat your patients. And it really affects everything. If you're involved in research, it can enrich your research. I just would really encourage you to get involved particularly if you care for a lot of lung cancer patients.
And I'm going to leave with the last word, which is, it is the best hour of my week, hour and a half now. And for me, I feel so great about what I can give back to my patients who give so much to me. So I really feel like I'm benefiting my patients in a way that they can't get benefit anywhere else, that my team is behind them, that, and then my professional relationships are so enriched because of having had a multidisciplinary tumor board. And it makes me want to do more for our cancer center. It makes me want to do more for my patients. And it makes me want to be a better doc because I'm being pushed by some really, really smart people around me. So I do agree with Katie, who says, get involved if you can. And so with that, I want to thank this incredible panel for participating. I think the discussion was as good as I've ever seen around a multidisciplinary tumor board. I thank them for their time and their expertise. I want to thank Lily Rodriguez from CHEST for helping with all the technical work. I'd really like to thank AZ for sponsoring this along with CHEST. Working with our colleagues in industry, it doesn't always have to be competitive. It can be collaborative, and this collaboration has been a wonderful one. So thank you so much for the people that are attending, and I'll say goodnight.